Good morning, everybody. Happy Friday. Welcome to another session of Changing the Way We Work, the community of practice for Ontario physicians. I'm Eleanor Colledge. I'm a family physician. I work in East Toronto, and I'm also the CPD program director for the DFCM. I'm delighted that we can continue to bring you these sessions in collaboration with the OCFP. And I'm going to turn things over now to Dr. Jobin Varughese to introduce the section.
Thanks so much, Eleanor, and welcome everybody. We're thrilled to have this session. It's a jam-packed session, so I won't spend a lot of time, but I do want to do our land acknowledgement to welcome everybody. So we have we'll have everybody introduce themselves in a second. The same thing I always say, which is this is a 1 credit per hour group learning session, and we will be taking care of that for you. There'll just be some delays possibly with applying it to your account. Next slide. We acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and the DFCM respects that the Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Next slide. So just a quick reflection to say that one of the biggest things that we want to do is ensure that when we are doing any of these sessions, that we focus not only on how it'll affect us, how we'll be able to grow from it, but how we can actually change each other and the way we work. And just like we are doing with any of these sessions, we want to be able to do that in a way that focuses both our abilities for how we can do things in our day-to-day work, but also in our work with our patients. So the sessions that we're going to go through are new and innovative, and I'll hand it back to you, Eleanor, as we move to the next sections.
Thanks very much, Jobin. And I'm calling in from Toronto, as I mentioned, the lands that were traditionally used by the Wendat, the Anishinaabe, the Chippewa, the Mississaugas of the Credit, and the Haudenosaunee. So we have a terrific set of panelists joining us today, and we'll start just by doing our introduction. So next slide, please. I'll turn things over to Dr. Dan Warshafsky to introduce himself.
Hi, morning, everybody. Dr. Daniel Warshafsky. I'm one of the Associate Chief Medical Officer of Health in Ontario, and nothing to disclose, and I was glad to be here. Thanks, Eleanor.
Great, thanks, Dan. And now over to you, Dr. Mariam Hanna.
Hi, guys. I'm Dr. Mariam Hanna, pediatric allergist and immunologist. I'm the chair for the OMA section for allergy and immunology. A whole bunch of people like me to talk about eczema and asthma and food allergies. Nobody ever wants to hear me talk about vaccine allergies, so nothing to disclose, but you see them there.
Great, thanks, Mariam. Next slide, please. Over to you, Dr. Vanessa Redditt.
Hi, my name is Vanessa Redditt, and I'm a family doctor here in Toronto. I received some funding for this session through the Ontario College of Family Physicians and some funding through the Health Commons Solutions Lab, which is a nonprofit population health lab doing research, but no conflicts of interest for this talk.
Excellent, thanks, Vanessa. And over to you, Dr. Doug Gruner.
Yes, thank you. I'm a family physician here in Ottawa, Ontario, and I received a small honorarium from the OCFP, but no conflicts regarding this talk. Thank you.
Thanks, Doug. Over to you, Jobin.
Hi, everybody. Jobin Varughese, president of the Ontario College of Family Physicians. I also hold 2 roles, one within Toronto Metropolitan University and one through Osler Health System.
Great, thanks, Jobin. And I've already introduced myself, but I do receive an honorarium from the OCFP and for some work that I do with the Foundation for Medical Practice of Education, neither of which pose a conflict for today. Next slide, please. So just a reminder for any of you that are new to these sessions, in terms of participation, we'd love to get your questions. Please post them in the Q&A. And if you see a question that's already there that you would like to see answered, then please upvote it because I'll be prioritizing those that are highest in terms of the upvotes. And then just in terms of the chat, we love the use of the chat for sharing resources, comments, and basically networking with your colleagues. Next slide, please. So without further, oh, actually, I'll just give you an outline of how we're going to run this morning. We're going to start by hearing from Dan and then Mariam, and then we'll break for Q&A, and then we'll turn things over to Vanessa and Doug. So over to you now, Dan.
Great. Thanks, Eleanor. Hey, everybody. So I'm going to give just a quick update on seasonal updates and what's happening in Ontario, and then a little segue into what Mariam's going to talk about. So if we can go to the next slide, please. There we go. So respiratory season, we're thankfully basically over at this point, which is really, really nice. It felt like a very, very long respiratory season, and the weather has not helped. In terms of the big picture of what we saw this season, COVID was at moderate levels for COVID. What I would do want to emphasize that when I say moderate levels for COVID, that still means over 1,000 people in hospital on peak days just from COVID alone, which is certainly more than what we see for things like flu or RSV. So we got a little bit lucky that it wasn't a bad COVID year along with what were actually quite significant RSV and flu years. But even a moderate COVID year is still more impactful than any of the other ones. So just always keeping that in mind, how significant a burden it is on hospitals and the morbidity that we're seeing from COVID still. In terms of flu, this was a very significant year for flu, highest in terms of hospitalization since 2017, 2018, with almost over 800 at peak beds at one time from patients. But we have been on the way down for a little bit of time now. We had a bump from influenza B later in March, as we always see. A B is a little bit later, but the big A wave was peaking in late February. And then for RSV, again, a very significant year for RSV, so even worse than we saw 22, 23, and peaking probably about mid-January as a whole. If we go to the next slide, please. And this is just the breakdown by age. So really just picking out the over 65 from kids under 4. As you can see for COVID in the bottom left, kids are almost nothing in terms of the COVID hospitalizations. So that's always nice to see. For bottom right for flu, so we do see significant increase in hospitalizations in children from flu, and that was very noticeable this year. It's nothing compared to what we see for older adults, which was again the majority, but it's still contributing, 50 to 100 beds even at peak, what we saw for kids. So it is a burden on the system, and certainly a lot of kids were getting very, very sick from flu. RSV, of course, is the one where we see most of the pediatric hospitalization this year. Children were not the main part of our RSV wave. It was by and far and away seniors. So you can see here, even though the overall wave compared to 22, 23 was higher, but not extremely higher, if we're looking at the seniors part, that was really where the burden came from. So nearly 300 hospitalizations for seniors at a given time. Whereas for children, we had a slightly better year than even last year. And again, we're hoping that this is from our infant immunization program that we saw. So that's the quick summary. And again, at this point, we're really out of the season. So the data I have here is delayed about a week. So you can see those trends are continuing to come down, but our percent positivity is now very, very low across the board. RSV is essentially done. COVID is extremely low. Flu is still on its way down for hospitalizations, but the percent positivity is dropping a fair bit. So we can happily say we're really exiting the respiratory season at this point. So next slide, please. So quick update on what we're seeing on measles. So the outbreak, which had begun in October of last year, but really took off starting in January of this year. You can see here that we're seeing very, very high case numbers. So we've still been averaging in around 100 new cases a week for roughly the past month. It's dropped down a little bit in the last week. We had about 60 or so cases. And then just for the last 2 weeks here, you can see we're still waiting a little bit on some of the data. But about 60 in the last week. So hopefully that's a sign that we are on the downward trend for measles as a whole. But again, this has been huge in terms of total number of cases. So as of this epi report from PHO, we're over 620 total cases related to this outbreak since it started, which is, the highest we've seen in Ontario or Canada in almost 30 years. The last highest one there was a large outbreak in Quebec in 2011. That was about the same number of cases, but certainly in Ontario, this is much higher than anything we've seen in a long time. Next slide, please. And just a reminder, so immunization really, really works. So you can see the vast, vast, vast majority of cases have been individuals who are unimmunized. The majority of cases are in children and adolescents, so that under 18 group accounts for about 75% of the cases that we've seen to date. And again, the vast majority unimmunized. We have seen some more cases in older adults, so in the 20 to over 40 range. And again, still vast majority have been unimmunized, just more of them don't have access to their records, so we have a bigger bunch of unknowns in there. But it's likely that many of those unknown records are really probably people who are unimmunized or underimmunized as well. Next slide, please. I just want to share this one because I think where this is happening is a really key point here. So if you look through the list of names here of health units that have cases, there's 13 health units that have outbreak-related cases to date. All of them are essentially in Southwestern Ontario, other than one or two. So Southeast Health Unit is in the Hastings area. There was an introduction into a particular unimmunized population there, but it's been very contained within that group. The rest of these are really within the southwest part of the province, and that's where the vast majority of cases are happening in historically unimmunized and underimmunized populations. So I think the big message about this is that while we are seeing this large increase in measles in Ontario, this is really a very localized risk. If you're not in southwestern Ontario in these health units, your risk of measles, unless you're part of one of these underimmunized populations, is essentially the same as it's always been, which is very, very low for the general public. The other things that are really nice to see is that the number of cases that we've seen outside of these underimmunized populations, so into the general population whole, is extremely few. At this point, I want to say it's 8 that have been confirmed that are outbreak related and not part of these underimmunized populations. And we have not seen spread from any of those cases further in the general population. So that means that the immunity that we have in the community as a whole from our very, very good measles immunization that we've had for years now in Ontario is really holding quite strong. And it's particularly these populations are unimmunized or underimmunized. So just if you're speaking to patients and counseling about the risk, do I want to get that vaccine dose early for my baby who's under 1, or get my second dose early for a child who's under 4? Really, like, talking about the risk and rationale is the important part here. If they're living in southwestern Ontario in these high-risk areas, that makes a lot of sense. And the particular health units that are highest risk have spoken about the modified program they're suggesting. If you're outside of this region, unless somebody's traveling and staying with family in a population like this, or globally traveling somewhere where it's really high risk, then getting that early dose is probably not something that's needed or really recommended at this time. The other few points I just want to say about measles is, number one, in terms of your protection, like yourself, your staff, if you're up to date with your 2 doses, we're very, very happy. This isn't like COVID where the risk of transmission is high. Yes, we should still be wearing masks and PPE, but the chance of transmission is extremely, extremely low if you've had 2 doses for yourself and your staff. And then lastly, just please do the testing in your offices. It's the same swabs as we have for viral testing. Serology is not the most important. It's a nice to have, the serology, but really the important thing is that you have an oral pharyngeal swab and a urine. Send those PCRs off. Those are relatively easy to get. It doesn't have to be a deep NP. You can swab their throats and get a urine and send it off. And that's really what we need to be really, really confident about the testing. So hopefully people are able to do that and see those patients at the end of the day, still don't have them interacting with the rest of your patients, but you should be able to do that hopefully in everybody's offices. Next slide, please. Okay, I'm going to roll into the transition now to Mariam's chat. And first just talk about antimicrobial resistance as a whole. And so I'm sure we've talked about it, it's come up many times on this call, but this is an enormous burden to our healthcare system and to patient populations. We have every single day in Ontario, and this is 2018 numbers, so we can only assume that the numbers are higher, 6 Ontarians a day died due to antimicrobial resistance organisms. That's a huge burden that we're seeing every single day from it. If we're talking about the costs, and these are estimates again from nearly 7 years ago now, in 2018, it was costing our hospital system almost $500 million a year. And so we can only imagine what that number is looking like now. It's much, much higher. And AMR infections require much longer treatment times in hospital, more staff, more risk of spread to other people, and disproportionately affecting some of our most marginalized and vulnerable populations in Ontario. So this is a huge burden and something that we really are working very hard to improve on. We've had some great improvements, like the rates of C. diff. I think we all remember 10, 15 years ago when C. diff was running rampant in our hospital systems. Through antimicrobial stewardship programs, through a really effective IPAC, we've been able to bring that down and stabilize those numbers. But again, this remains a significant burden to the system. So go to the next slide, please. So to get to some of our allergy labeling, penicillin specifically, penicillins are still first-line treatment for many very, very serious infections, infections which have been on the rise in Ontario. Syphilis is, the hallmark, but we have seen over the past few years, not just increase in syphilis cases, but things like congenital syphilis as well. So this is really a huge burden. And again, disproportionately affecting individuals who are in shelters, people who are experiencing homelessness, as a group that really is suffering from the expanding syphilis infections that we've been seeing. Group B strep for postpartum. Again, this is something that penicillin is #1 use. And this one, I think we can all remember, but the last couple of years in terms of invasive group A strep have been significantly higher than we've seen previous seasons. And again, this is penicillin that we're using for treatment of post-exposure prophylaxis in those infections. And penicillin, that's really the best and only thing we have for invasive group A strep. We have no vaccines. It's something that's very hard to predict and identify in patients. So we really need to be able to use these first-line treatments in order to make sure that we're best managing what, again, are very serious infections that have been increasing in Ontario. And with that, Eleanor, how's that transition?
That transition, sorry, slow to get to the here. That transition was amazing, Dan. You've pointed out why we really need the next talk, so I'm going to turn things over to Dr. Hanna.
Here with the next talk is me. Okay, so the pathways to appropriate penicillin allergy delabeling is a 2-page handout that the Ontario Medical Association section for allergy developed. If you remember back during the COVID vaccine allergy concerns, we created a very similar pathway to be utilized for that. So what I'm going to show you today is just some of the logic behind it, how to use this resource, and other resources that you can link to for assistance with this. And obviously your neighborhood allergist can also help you with this. Next slide, please. Choosing Wisely in 2021 asked the Allergy and Clinical Immunology about 7 things that we could do as clinicians and to help with our patients. And one of the things that we should not do is avoid antibiotics and particularly penicillin unnecessarily. And just exactly what Dan said, it leads to more antimicrobial resistance, longer hospitalizations. We have more MRSA. These patients are very easily delabeled, and we are looking at about 6 to 25% of the general population that walks around with this label of maybe they are penicillin allergic. Next slide, please. So this is that pathway. You may have seen it in the OMA news a couple weeks ago, and it'll be posted in the chat as well if you want to download that. Next slide, please. So what we did is we separated the patient populations that you're going to see into the lowest of risks. They don't need an allergist. They don't need any particular testing, and they can just be reassured and receive their amoxicillin prescription as appropriate. Obviously, keeping in mind that we want to not necessarily treat all infections with antibiotics. We are seeing quite the increase in rate of unnecessary prescribing of antibiotics as other healthcare providers are prescribing them very rapidly, and that's certainly always an issue. But patients with atopic histories in general, this does not increase their risk for a specific medication allergy. And if they have a medication allergy to another class of medications that is non-penicillin or even an injectable type of medication, this does not personally increase that patient's risk for a penicillin allergy. So all these types of atopic patients or patients with history of drug allergy don't necessarily need to avoid amoxicillin or penicillins unless they are suspected of having a reaction to penicillin. Those that have mild side effects that are common to antibiotics. So you know which ones we're talking about here, the ones with the non-specific abdominal pain, headache, nausea, diarrhea. These are not IgE-mediated symptoms. These patients can safely be reassured and prescribed as appropriate. And the last one is family history of atopy or family history of multiple relatives of penicillin allergy does not increase your chance of having penicillin allergy yourself or for your child. And again, penicillin can be safely prescribed in this instance. And so this is where a lot of reassurance can be provided to families. You can even point them to this reference and say, you know, these are all a population that don't need a referral and can be safely prescribed. Next slide, please. This next group represents those where we may want to suspect a penicillin allergy. Now, again, depending on the patient population, you can expect about 80% of your patients may be delabeled following evaluation for penicillin allergy. And that number can go up to 95% in our pediatric population that honestly get a ton of viral rashes when they are on antibiotics. The patients that we are referring to here have more IgE-mediated symptoms. They have rashes, be it urticarial, erythema, angioedema, non-specific maculopapular rashes, as we get a lot of. They may have more concerning symptoms such as respiratory symptoms with trouble swallowing, difficulty with cough, wheeze, shortness of breath, or hoarse voice or sensation of tightness in their throat. And then the most concerning would be the cardiovascular ones. These are particularly patients that receive an IV dose of penicillins where they may develop pallor, hypotension, dizziness, or a syncopal episode. So first of all, documentation is the single most helpful thing that you can do for us in helping us understand what's the concern with these patients. We specifically want to know why they were prescribed that amoxicillin or that penicillin for whatever that reason was, and when symptoms started, roughly speaking. Symptoms that occur within 14 days of starting a penicillin are a concern. So document what it is that's happened in as much details as you have. And then those guys are the ones that are going to be sent for either skin testing and or a challenge to penicillin as deemed appropriate. And we can talk about the nuance of when we skin test and when we don't. But in general, a negative skin test is super helpful for penicillin allergy and moving on to an oral challenge in adults. In kids, most low risk stories in adults and kids will just go straight to oral challenge. There are some patients that have also been previously tested to penicillin. And if it's been some time, meaning it's been 5 or more years, it's actually worth reevaluating those patients. And then next slide, please. The last category of patients are the ones that are at highest risk of this lifelong penicillin allergy label. So I see a lot of those that have kind of non-specific rash in childhood, they carry the penicillin allergy label for life. That's not necessary. But these guys, they should carry the risk for potentially life. So these are the patients that have scar-like reactions, so severe cutaneous reactions to penicillin, or end organ damage like liver or kidney, or have an ICU visit because of a penicillin that they received. You can agree with me quite easily here. These are the guys where the juice is not worth the squeeze. It's the way they say it sometimes. We get a referral for them. We want to discuss with them, oftentimes these are patients that are quite sick and may have been on multiple medications at the same time. So we really want to narrow down the list of what it is that they need to avoid. If necessary, or if deemed worth it, we may desensitize these patients. Most of the time, we're talking about medication alternatives as appropriate. Next slide, please. Penicillins and cephalosporins. Okay, this goes back to the 80s. There was this cross-reactivity concern, and it still persists, and we talk about it a lot, but it should be debunked amongst physicians and amongst patients to say, in the past, we used to worry that they shared the same base or they shared the same side chains, and that we should avoid all cephalosporins while being concerned about amoxicillin or penicillin allergy. That risk of cephalosporin allergy in general is quite low. So you can talk about those with true penicillin allergy have about a 2% risk of having a cephalosporin allergy. And if it's self-reported or an unconfirmed penicillin allergy, that risk goes down to 1% because again, 80 to 95% of those kids with penicillin allergy or queried label are not actually allergic. That similar chemical structure, once again, doesn't typically contribute to an allergy, so they can safely be delabeled or no concerns and prescribed as normal. Next slide, please. A reminder that the e-consult service is available, and there is a small base group that's been created now specifically for peer-to-peer conversations about penicillin allergy advice. So if you need advice or want help troubleshooting a patient or just talking about a particular patient, feel free to send in an e-consult with this. Next slide, please. I'll bring your attention to the plethora of allergists located around the Golden Horseshoe area. So you may have lots of allergists in your area. or you may want to consider an e-consult or referral. We're also coming up in the spring of 2026, so we might be a year out from doing this. We will have penicillin delabeling clinics in more remote communities up north, and we're very excited about that. We want to target marginalized communities and rural communities because this is really where that label of penicillin allergy can make a huge difference in the patient outcomes. Next slide, please. Okay, so I've reached the end of my section, so we'll open it up to questions. There are resources that are at the bottom of that 2-page document. One of the resources that's there is a podcast. My conflict is I also help run this podcast. This particular episode that you see the QR link here is specifically talking about penicillin allergy and the burden of this and how we delabel and why we do so. So if you're interested in hearing a little bit more about this, that's a good topic for you. Joining for the Q&A is also one of my dear colleagues, Dr. Zainab Abdurrahman. So Eleanor, I'll open it to Q&A for this part. And I think Zainab's also on with us.
Great. Thanks so much, Mariam and Dan, both for some excellent presentations. Quite a few questions that we'll get to, and I think maybe we'll start with you, Mariam, just because we've just heard from you. I mean, I think, first of all, there were a couple of comments just about the challenge of finding an allergist. This came up in the chat, actually, that there's very long wait times. You had mentioned e-consult specifically for for allergy delabeling, but what about for other services, just generally in terms of allergy referrals?
So great point. It does depend on the region, and it does depend on what is the indication or what kind of testing is needed. So there are allergists in the community, and if you need help troubleshooting this, we can do it probably offline. But many of our allergists in certain regions have wait times of 1 to 3 months, and there are other areas in Ontario where it's like 1.5 years to see an allergist. And this discrepancy is unfortunate, but there's a lot of stuff that we can do virtually, and there is a lot of stuff where, you know, if the patient is willing to travel, an allergist can see them for these issues.
And if I could just tack on to that, Mariam, what I would say is e-consult is really helpful because you could also use that to float your idea about how quickly they might need to be seen, or if it's something that may not actually require to be seen in person, can be done virtually. You could also use that to troubleshoot if you do have very long wait times in your community. So you can also use that, or even to help with some treatment in between. So utilize that kind of to help you as well.
Thanks so much, both of you. Just in terms of antibiotics as well, there was a comment question here, is our antibiotic prescribing a drop in the bucket compared to other countries that have antibiotics sold over the counter? Just wondering what your thoughts are on that as an allergist who's probably thinking about this more, you know, on a daily basis.
It certainly is, and I think we see as other non-physicians get prescribing abilities that is shifting even here.
Agree. I think we've all seen an increase in our questions about possible penicillin allergy with the increase in other people prescribing, because we're not able to use that antimicrobial stewardship that is so ingrained into physicians. And so now we're having a lot more of these questions.
Great. I think along those lines, people were wondering if there is a way to prevent like sort of the antibiotic prescribing that sometimes happens at walk-in clinics and perhaps by pharmacists as well. I don't know if you guys have any thoughts on that.
This would be a multi-pronged approach, which the lowly allergist me will not overstep into. But there are challenges to feeling like patients have been heard, have timely access, the acuity of their symptoms, the pressures that are on our healthcare system. But like some of the virtual walk-ins and the urgent care centers and the pharmacists prescribe, like there are so many challenges that we are facing, and we are getting a lot of patients that are getting overprescribed, overdiagnosed with things that they may not necessarily need antibiotics for. So I can identify the issue. I'm challenged by the solutions. Zainab?
I think that it's, you know, almost going back to some of those to that education that we did on a larger scale, because it's the need for the antibiotics, or the want for the antibiotics, is coming also from our patients. And so trying to do that on a large scale education. So that sounds a little bit more like public health. And pass to Danny. Just kidding.
Yeah, I mean, I think these are really challenging issues, and there's some comments in the chat about, you know, pharmacists. It would be helpful if they saw this talk as well, which there may well be some pharmacists on here. So
Right.
yeah. A couple of questions. So in the context of AMR, wondering what your thoughts are on the widespread uptake of doxypep and how we limit AMR risk while not gatekeeping those, you know, from those that need it.
Sure, I think I can take this one. You know, obviously, for those who don't have any kind of contraindication or any prior history of prior issues, should be able to have access to it. If there is a concern, it is good to get them delabeled early, because obviously this is a great preventative measure that we want available and accessible. So if anyone does have this label, even starting with a chat with them as to why they have the label, what the history was, and then interacting and trying to get them delabeled as quickly as possible, because this actually is really important for prevention of STI. So we want those who have access to it to be able to use it easily.
Thanks, Mariam. Another question, just in terms of the treatment of gonorrhea, that the guidelines still say not to give a cephalosporin to people with a penicillin allergy. So just wondering, does this require a change given what you've just said about cross-reactivity?
It's long overdue. And a lot of these recommendations or these updates take a while to translate into all the other guidelines that are there. But for sure, this is long overdue.
Great. And a quick question around skin testing and oral challenge. Is this covered by OHIP? I would assume yes.
Yes. The answer is yes.
Good to hear. And another question, what are your thoughts about using the PenFast risk calculator and doing in-office challenges in family practice offices for low-risk individuals?
Yeah, so the PenFast score is something that we really like using, and there are some of the provincial pathways that'll actually also use the PenFast score in them. BC would be the one that I can think of off the top of my head. The patients that are in that green box when we showed you that COVID pathway, they don't need a PenFast score. Their score is 0. There's no concern. They could just go straight to being prescribed. And so in some ways, I would say, like, I don't also require unnecessary oral challenges to happen. We don't need to overburden our system in that way. But certainly the PenFast score is some of the things that we will utilize in our office to decide who can go straight to challenge versus who needs testing and who needs extended observation. And this is where working with an allergist is quite useful. Okay.
Great, thanks, Mariam and Zainab. I'm going to ask you one quick question just regarding, because it came up around the allergists and accessibility. Do many allergists do e-referrals? I know there's e-consults available. Just wondering if that's something that's also out there and available.
Yep.
Yeah.
Absolutely. There's many allergists on the e-referral pathways. And if you just search allergy, depending on your different locations with how you access your e-referrals, you can find the different allergists in your community and use e-referral pathways. As Mariam showed, there's also that CSA-CI Find an Allergist. I think some of the things that we also need to look at is just, there's always new allergists coming around, and we're trying to also find ways for newer allergists to get their information out so that they're in your community, because in the same communities we practice in, we know that there are allergists that have a 1 to 2 year wait list, and some of us might have a 1 to 3 month wait list, and we're in the same community. And it's about how we also get that information out. And I know that kind of leads into our bigger talk about centralized referral pathways, because we obviously don't want that burden to be put on anyone in the healthcare system to have to be searching. But we're also trying to find ways to get all the newer allergists to be on things like Find the Allergist, or get their information out to their community so you know they're there.
Great, thanks very much, both of you. So I'm going to turn things over to Dan. We're going to do some rapid fire questions before we get to our next session, just because I know there were a few things that I wanted to cover before we move on to Newcomer Health. So one is just, can the changes to the COVID therapeutics be addressed, was one question.
Yeah, I can do that quickly. So the updates to the treatment from Ontario Health is really for inpatient severe COVID. It's not big changes from before. It's really still starting with dexamethasone, and depending on the severity and other complications, you'd be using either remdesivir or things like tocilizumab or baricitinib. But again, that's for inpatient severe cases. The outpatient guidance has not yet changed in Ontario Health, so it still has the same pieces on Paxlovid or remdesivir. But to speak a bit to the evidence, as we get further out, vaccination rates remain high. We're seeing that the benefit of Paxlovid in those who are younger with fewer comorbidities is less and less. So if we're talking about, a 50-year-old with just diabetes, they're probably not going to see that benefit in terms of reduction in hospitalization. They may still see benefits in getting better a little bit earlier, like maybe 24 hours earlier in terms of symptom reduction, but not the hospitalization benefit. Whereas it's really age-based, over 65, particularly over 70, 75, we see significant benefits in reduction of hospitalization, and then individuals with multiple comorbidities. So I think the Ontario Health guidance as it stands is still up to date with the evidence. Again, age-based primarily, and then if you have patients with multiple comorbidities, that's where the other benefit is for reduction in hospitalization.
Great, thanks so much, Dan, for clarifying that. And we're going to take one more question, and then I'll note that you have answered a bunch of the questions, typed out some answers. So for those of you who might have asked some questions around measles, the answers are there. And if we have time, I'll read some of them out loud towards the end of the session. But a couple of questions just around like COVID vaccines. Should we be giving them to high-risk seniors now or waiting for, the fall? What's sort of the thoughts around the spring COVID shots?
Yeah. So there will be a spring program. It should be announced like any day now. To be quite frank, the election just means that a lot of communications were paused. So things didn't go out as quickly as they might have liked to. But there will be a spring program. It will look very similar to last year's spring program. It is still with the same product. So the vaccine manufacturers only update the fall. So it'll be the same one they were given before, but it's still the spring. Really, it's this for those highest risk groups, like particularly older adults and immunocompromised individuals. That's who we're suggesting should get at the spring program.
Great, thanks so much, Dan. We may come back to you after the next session, but thank you. I'm going to turn things over now to Dr. Redditt.
Great. Thank you so much for this opportunity to speak about caring for newly arrived refugees in our primary care practices. So obviously this is a very broad topic, and we're just going to be providing a brief overview focused on health coverage and initial screening and clinical considerations today. But we look forward to, excuse me, opportunities to explore these topics in more detail in future sessions. Next slide. So to begin with, we want to start with the definition of a refugee. And this is a person who is facing persecution based on reasons of their race, religion, nationality, membership of a particular social group, their sexual orientation, or political opinion, and they're outside of their country of nationality and unable to receive protection from that country. And this really has implications for how people cross borders and for their immigration status. Next slide. In the Canadian context, we have two main categories of refugees: resettled refugees and refugee claimants. In the case of resettled refugees, there are government-assisted and privately sponsored refugees. And these are individuals who are identified usually through UNHCR and approved as refugees before coming to Canada. So they are permanent residents on arrival. We'll be speaking to their healthcare coverage. And just a note that they receive a year of financial and social support. In the case of government assisted, this is federal government funding, and then social support from settlement agencies. And in the case of privately sponsored refugees, both the financial and social support comes through their group of sponsors. In the case of refugee claimants, otherwise known as asylum seekers, these individuals arrive to Canada and make their claim either at a port of entry, like the airport, or after arrival. And then they wait for their refugee hearing, which on average right now is taking about 2 years. So they face a long period of uncertain immigration status. Many of these individuals will receive financial support through Ontario Works, social assistance, until the time that they can get a job, if that's possible. And many individuals may spend time in the shelter system, as well as have some connections to a network of community organizations, but that can be quite variable. So there is quite a bit of diversity in the social support that they might be receiving. Next slide. One of the main points that we want to make in this presentation is that all of these categories of refugees have comprehensive healthcare coverage. And next slide. This is through the Interim Federal Health Program. So it provides for both basic coverage, so everything covered under OHIP, like seeing a doctor or nurse practitioner, diagnostics, laboratory tests, hospitalizations, as well as supplemental services, which include medications, dental, vision, allied health like physical therapy and counseling, and medical devices and equipment. These supplemental services are very similar to what individuals on social assistance would be receiving. So the coverage is in place for a year for privately sponsored and government-assisted refugees, and until a refugee claim is accepted in the case of claimants. Next slide. The key here is that we need to be enrolled in the IFHP program, which is administered through Medavie Blue Cross. So it's an easy process to register yourself as a provider, and essentially your billing will go to IFHP rather than to OHIP. It's a simple process, and you're going to be using the same diagnostic and billing codes as you would with OHIP. The other important point here is that we also want to be referring patients to IFHP enrolled providers, whether it's a physical therapist, a counselor, or a specialist in the case of refugee claimants. So a note here, next slide, that healthcare coverage for government-assisted and privately sponsored refugees, they will have their OHIP cards for their basic coverage because, again, they're arriving as permanent residents, and then they're using IFHP for their supplemental services for that first year. And it's really just in the form of this white paper that they need to present at the pharmacy or other services. Next slide. In the case of refugee claimants, they are using IFHP for all of their coverage, both basic and supplemental. And so they'll be using what's often referred to as a brown paper or refugee ID. The photo is here for that they need to bring to the laboratory, to the hospital, to the physical therapist. Next slide. So now we're going to be getting into a brief overview of clinical considerations for newly arrived refugees. But really one of the most important first steps that we can undertake is to build a trusting and warm relationship using trauma-informed care principles, deep listening, and engaging in cultural humility. This is all so key to the care that we provide. Next slide. The clinical considerations that we'll be providing an overview to are really based on these CMAJ evidence-based clinical guidelines for immigrants and refugees, and the link will be provided. Next slide. We're going to be giving a bit of an overview of an initial intake. So of course, this entails a thorough history and physical examination, and then some considerations around screening tests, which we'll delve into. Also very important for us to think about immunizations, dovetailing after Dan's talk, and we want to touch on some mental health considerations. I've put a placeholder here for women's health. We unfortunately don't have time to address this today, but look forward to addressing it in future sessions. Next slide. In terms of infectious disease screening, here we want to consider exposures to infectious diseases based on the epidemiology in the countries that refugees have originated from or have migrated through. So we want to do serology for hepatitis B, testing for hepatitis C. For individuals who have been sexually active at any point, doing testing for syphilis, HIV, and gonorrhea and chlamydia is recommended. We want to do varicella serology for individuals who are 13 and over. In terms of parasites, we recommend testing for strongyloides with serology, given that it is endemic in most countries that refugees are arriving from. Schistosomiasis serology is recommended for refugees coming from Africa, the Middle East, parts of Asia, and a subset of countries in Latin America. And we have a resource that provides more details on those specific countries. Screening for latent TB is also recommended at this point using a TST. Hopefully we'll have coverage for IGRA in the future. And if it's not feasible to do this for all of your newcomer patients, at least prioritize those who are at higher risk of reactivation. Next slide. In terms of non-communicable diseases, there are higher rates of anemia, and so doing a CBC as a screening test is important. Also thinking about rates of hemoglobinopathies like sickle cell and thalassemia, so doing a hemoglobin electrophoresis for most patients is appropriate. And also doing lead levels for children who are under the age of 7. And then, of course, thinking about age-appropriate diabetes and lipid screening, as well as age-appropriate cancer screening. So next slide. We are pointing you to some helpful clinical resources. This is a checklist that was developed by colleagues in Ottawa, including my colleague Doug Bruner, that looks at the screening guidelines based on regions of origin for refugees. Next slide. And this next resource is from colleagues in Calgary, and it provides additional information about these recommended screening tests, as well as guidance on what you can do when you face an abnormal finding, such as a positive strongyloides or schistosomiasis test. Next slide. In terms of immunizations, this is a really important topic, considering that individuals may have had gaps in their healthcare and may not have received vaccines, or there can be differences in the immunization schedules in their countries of origin. So what we do is we review previous immunization records if they're available, and we can fill in what's missing based on what we offer in Canada. Otherwise, we offer the full series of vaccines if they don't have records, providing reassurance that it's safe to re-immunize. So in the case of adults, we want to ensure that they've received 1 or 2 measles, mumps, and rubella shots, that they receive a primary series of tetanus, diphtheria, and polio, one of which should include pertussis, and then considerations about regarding meningitis vaccines based on their age. For children, we can do catch-up schedules, or we might be starting from scratch. And then again, just that reminder, in the case of varicella, we've checked the serology in those that are 13 and over, and we can vaccinate those who are non-immune. And for children, we just give them the vaccine, unless they have records that they've already received it. And for hepatitis B, we have done serologies both to identify infection and immune status, and we can offer the vaccine to those who are non-immune and eligible to receive it. Next slide. So mental health issues are a huge topic for refugee newcomers, and we wanted to provide some brief guidance here. So the guidelines suggest that we shouldn't actually screen specifically for trauma, but instead be alert to somatic symptoms and other signals that may indicate mental distress. And we don't need to know the details of individuals' trauma in order to respond to it sensitively. Next slide. It's really important for us to remember that stress and trauma can manifest in very different ways at different points in the migration trajectory. And so people may need and want different supports. Some individuals on the first visit tell me that they would like counseling, and other people say, you know, I don't want to talk about my past. It makes me sad, and they want to join a soccer team and be learning English. And so next slide. Really, we have an opportunity to first and foremost address mental health concerns by focusing on social concerns. Next slide. And promoting resilience is really about ensuring that people have opportunities to learn English, that they are involved in educational opportunities, that they are on meaningful pathways towards gainful employment, safe housing. And not that we can necessarily take on all of these responsibilities in our clinic, but we have an opportunity to help individuals connect to these resources, to community organizations that really play such a critical role in addressing these social determinants of health. And it is just such an honor to be involved in this care, and we look forward to opportunities to explore these issues in more detail. Thank you so much.
Thank you so much, Vanessa. We really appreciate you speaking to us today. And I'm actually going to, first of all, I just want to say for giving a very brief talk on a very large topic. So we appreciate you giving us some, the starters in terms of how to address these issues for newcomers. But I'm going to turn things over to Jobin as he has a question to ask the group overall.
Thanks, Eleanor, and thanks everybody. Just to say that OCFP is in partnership with the DCFM developing a new stream of community of practice sessions focusing on enhancing care for marginalized or underserved populations to help support family physicians to care for care of the patients who may have unique needs. And so I'm launching a poll here to actually ask the question about to help us identify the areas of practice that we should prioritize so that we can best support you. You can feel free to identify as many as you'd like. And if you have an area that's unlisted, please use the open text box to share your thoughts. We also will include an opportunity to ask the question again in our post-session email, so that if you think of something later, that there'll be an opportunity to share. So while that's going, and it's going wild, we have lots of people answering. Thank you for that. What we'll do is we can take down the slides, and then when I come back after some of the questions, I can share the results of the poll. Thank you. Eleanor, back to you.
Great, thanks very much, Jobin, and hopefully people can participate in that poll so we can gain some insight into what else would be helpful for folks to know. So a couple of questions, one just actually more of a comment or a question regarding IFH. There was a comment in the chat that actually apparently for nurse practitioners, it's not covered. And I just wondered if you had some thoughts on that, if there's some movement there.
Yeah, I'm sorry, I should have clarified. That's really right now in the context of family health teams and when they're in hospital settings, but not independent nurse practitioner facilities, that, we expect there to be changes. So something to keep an eye out, and point very well taken that this change is so needed to expand access, particularly, across Ontario where there may not be family physician offices or family health teams.
Great, thanks very much, Vanessa, for clarifying. Another question for newcomers, is there a resource to help check newcomer immunization records, especially when they're incomplete or not in English? Wondering if you've had any success with finding a resource for that particular challenge.
So at this point, actually, go ahead, Doug.
No, I was just going to say, I did kind of address a little bit of that in the chat with the Q&A, but basically we have really great support, at least here in Ottawa, with our public health unit. So if they have partial records, or if there's any, uncertainty, we often liaise with public health. But again, I think Vanessa addressed this in her talk, is that if they've got no records, you're basically looking at doing a primary series with adults and children as well, potentially, depending on what type of records you do have access to. I'm not sure if you have anything more to add to that, Vanessa, but
yeah,
that's what here.
Yeah, and sometimes what we're doing is we're just checking it against the Ontario immunization schedule, seeing what they have and what's missing. And I think that the public health units vary in terms of how much support they're able to provide in that regard. For us, we're really managing it on an individual basis.
Great, thanks very much. Another question just around some of the tests that you recommended, I guess some of the ones that we'd be less commonly sending off, things like schisto and strongyloides. Can we send these just to a regular community lab? Do they have to go anywhere special, or what's that process look like?
Yeah, great question. So you can do it at any laboratory. The key here is that you need to use the public health lab requisition and list those serologies just as you would for, a measles or mumps serology. So you're not using just the MOH lab, you want to use the Public Health Ontario requisition.
Great, thanks very much. Another question, is there any routine testing that's done outside of Canada as a requirement for immigration and entry? And if so, do we need to repeat this testing if it's done already?
Yeah, I can take that one. I mean, essentially, there is a number of tests that they do. For example, a chest X-ray to rule out active TB. They do syphilis or VDRL testing, HIV. There's a number of other sort of public health related tests. Essentially, these tests are done to protect the Canadian public before, newcomers come into Canada. So our recommendation, generally speaking, is that we are, looking at the patient, and essentially we're doing the screening testing that Vanessa has outlined in the talk. So essentially, and again, they're not checking for latent TB. So, MAN2 testing, again, I also threw in the chat there, and Vanessa had outlined the resource that we use as far as screening. And that is something that helps guide us as far as, which tests to order. But essentially, we don't really worry about what's done outside. We're going to order our own testing.
Great. And I see, Vanessa, you popped in the chat the regular things that happen for anybody that's coming into Canada. Is that correct? That's what you've posted there?
That's exactly right. Yeah.
Excellent. Another question just around payment. There was a question, has Blue Cross improved payments? One physician was complaining that it doesn't always pay out or it takes a long time. Have you had, you probably do a lot of billing this way. What sort of experience have you had in terms of this process?
So I think that, there were, as many of you will be aware, there were cuts to refugee health coverage in 2012, and then the program was subsequently fully reinstated. But that caused a lot of confusion, both within the healthcare provider and within the public population and for refugees and refugee-serving organizations. I think that the system has improved. In my experience, the billings come on time and are complete, but there may have been some delays during that time, and hopefully those issues have been resolved. Doug, I don't know if you have any comments.
Yeah, I mean, I certainly have not had any issues. All of our providers at the Briere Family Health Team are registered with Blue Cross. It's pretty seamless. We get paid fairly, in a timely way. So we haven't noticed anything. And I think, to Vanessa's point, if providers are saying 10 years ago, that's exactly when, things were in complete turmoil. So things are very different now. But I can't speak for, the whole province, but pretty much Blue Cross has been fine for us.
And if I could just add there, I think that for primary care providers, the billing is quite straightforward. There are some procedures that a specialist might be undertaking, or special testing that requires pre-approval, and that can be a little bit more of the liaising with Medavie, Blue Cross, and IFHP. But for the regular billing that we would be doing in the office, it's very straightforward.
Great. I mean, that's wonderful to hear that it feels like it's a much more seamless process than it was in the past. Another question just around coverage. Can you please clarify which refugees have a waiting period for OHIP, if any of them do?
Great question. So the good news is that refugees do not have, the government-assisted and privately sponsored refugees receive their OHIP right away when they arrive, or they're eligible to. They need assistance to do that application, but they get it right away. So they don't have the same, waiting period that other immigrants may have experienced. In the case of refugee claimants, they're going to have their IFHP in that refugee ID document. When their refugee claim is accepted, they need to apply for OHIP, because then the IFHP is going to expire 90 days after receiving that positive decision.
Great, thanks for clarifying that. Another question regarding TB testing. So Dr. Redditt, would you recommend a two-step TST, or is one test enough?
So, many times what we're going to be seeing is that patients may be coming in with work forms, and for working as PSWs or volunteering in a hospital setting, and in that case they would require a two-step TST. But if they have a positive TST on their first step, then that is sufficient. I think that a two-step would be recommended. Doug, I don't know if you have comments on that.
Yeah, I mean, I think if there's not a specific situation, like, as Vanessa's pointing out, like that they require it for a work-related sort of thing, our practice is we're just doing one step. But again, I think, it will, each situation will be sort of unique, but essentially we're doing one step for most of our refugee, patients.
Yeah, and just a note here that there is active advocacy to bring IGRA under IFHP and a coverage. So hopefully that will be an option in the future, which is just a better test. It's easier for patients, for providers, more accurate.
Yeah, that would be amazing. And no doubt make it a lot easier for those patients that come from somewhere where they had the TB vaccine. There was a couple of actually not questions, but some comments in the chat just around like translators and language challenges when working with patients that are new to the country and English isn't their first language. Love to hear from both of you in terms of how you manage that in the office and any thoughts around that.
Yeah, I mean, I can take that one first, I guess, and then let Vanessa follow up. But essentially, you know, at the Briere Family Health Team, we played a fairly large role in, you know, helping Syrian newcomers, you know, resettle here in Ottawa. And as a result of that, there was advocacy around getting interpretation services through OLA, Ottawa Languages Access. And now we have that as part of our regular sort of, you know, ability to access that in our clinics. That's not always the case, obviously, for people outside of a family health team or FO. And so it's a lot more challenging. So as far as how to do that, this is something that is interesting. In Nova Scotia, they have, you know, province-wide access. So this is something that we're advocating for all family physicians and nurse practitioners, that we, you know, try to get the government to actually cover this. This is in process. Many other provinces, as I've mentioned, already have this ability. So Ontario is lagging behind on that, which is a crucial piece. Obviously, if you don't have good language interpretation services, it's a huge barrier.
Yeah, absolutely. I'm in my context, we're fortunate to be in an academic setting. So there is coverage through the hospital, and that may be relevant in some people's context, but unfortunately not in community practices. In some cases, you may be able to liaise with community organizations that can assist with interpreter services, which would be a bit context dependent. But as an example, Barbara Schleifer organization here in Toronto offers free interpretation for survivors of gender-based violence. So sometimes it's being a little bit creative with the resources in your community, but hopefully with advocacy, we can have more widespread access to interpretation services.
Yeah, I mean, that's great to hear that there's advocacy going on, because there was another comment in the chat about, you know, for non-English speaking newcomers, do you need a certified interpreter, not a family member, to provide service assessment to avoid personal bias and misinformation? And I think the answer is yes, correct?
Yes.
Yeah. Also, just a comment in the chat that Ian Pun was mentioning that he uses ChatGPT in real time to translate to English. So I guess that's another possibility, an AI, or not AI, a tech solution in some circumstances that you could use. I'm going to just turn things over to bring up our last few slides, because I notice it's 3 minutes to 9, and I know some people start their clinic at 9, and then we'll come back to finish off with a few additional questions. So I could just get the slides up again, Susan, that's great. Yeah, and I think you're up first, Jobin.
Yeah, absolutely. So I'm just going to quickly share the poll results and thank the group. I think it's so crazy that usually most people get 30% on their polls, but this amazing community gave us 55%, 246 people responded, so thank you. The osteoporosis and fracture prevention workshop will be present on April 30th. We recommend, if you haven't done this amazing project, this workshop, please consider doing so. Next slide. And just to point out that we have many more community practices going on, and as we've mentioned, this is another one that we'll be starting. So we'll make sure we send these out afterwards. Back to you, Eleanor.
Great, thanks, Jobin. So yeah, just a reminder of our past sessions, which are available online. Next slide, please. And the next slide, yeah. So next slide is our upcoming dates. May 2nd is the next one. We'll send you registration closer to the time. Next slide, please. And a reminder, of course, that these are Main Crow accredited, so you will get credits, although there might be a little delay just as the Cert Plus platform changed. And next slide, please. I think that's everything. Yep, so for those of you that need to sign off, I hope you have a wonderful weekend. And for those that have time, we'll answer just a few more questions before we finish off in the next few minutes. So if I could get the slides down, that would be great. And then actually probably we'll bring up all of the speakers because I think we have a bit of a variety of questions. I wanted to actually just go back to Dan first of all. I was hoping, because I know you answered a few questions in the chat, we wrote out the answers, but regarding measles, there were some questions about if you give somebody the vaccine early, so less than 12 months. Could you just speak to that live, just for those that are listening rather than reading or watching?
For sure. It came up a couple of times, so thanks for raising it, Eleanor. So, the short answer is if the child's at very high risk at 6 to 12 months of age, you should give them a vaccine now. If they're in Southwestern Ontario in one of these high risk communities, it's worth giving it because the immediate protection is more valuable than the better protection we'll get from a dose given later. It is age-based. So infants that are 6 months old, their immune systems are not as developed as an infant who's 1 year old, as you'd expect. And the first time you receive the dose does prime your immune response based on where it was at that time. But this is age dependent. So like an 11.5-month-old, we're not going to see a big difference. At a 6-month-old, yes, we do have studies. 6 to 9 months is really where we have very good studies showing that the long-term antibody titers are lower for infants who receive their first dose in that age range, even if they get 2 more doses later. What that translates to in effectiveness, we're not talking about a 30% drop here, just to be clear. Like, it's still smaller numbers relatively, but given how infectious measles is and the fact that we would really want to maximize protection, if you don't need it at that younger age, it's better to wait an extra few months to get it over the age of 1. But again, if they need it now, absolutely they should be getting it now if that risk is warranted.
Okay, and just in terms of that risk, there was a couple of questions about people that might be traveling with kids to crowded areas or other parts of the world. Could you clarify when you would give it, or if you would give it to those that are under 12 months that are traveling?
No, it's a good question. So there's certain parts of the world certainly that are very, very high for measles. So if they're traveling to, the parts of Texas right now where they're having a measles outbreak, that's a good idea. If you're traveling globally and planning to stay, with family in communities where we know that measles spreads more. So, that might be some countries in Europe that are still high. The highest ones we still see are mostly Southern Asia and Southeast Asia, like Pakistan has very high rates, Indonesia, those countries. And again, especially if staying with family. If you're going to hotel and touring around Europe, that's not really the risk. If you're flying to, Caribbean, that's not really the risk. It's about going to these areas that are high transmission that we have now. And again, particularly in staying with family in community, that's the highest risk.
Great, thanks, Dan, for clarifying that. I'm going to turn things over now to Mariam and Zainab. I'm trying to keep track of the 5 people on my screen here. So just a question regarding adult testing. So what criteria would an adult with a history of penicillin allergy need to meet to go directly to oral challenge versus skin testing first?
Such a good question. A bit nuanced. A lot has to do with like history, when the reaction occurred, what the treatments were required for that reaction, what was the initial indication for them to receive penicillin. Essentially, you want to risk stratify them in your mind before deciding like how likely is this a penicillin story that requires further testing. Again, intradermal testing and skin testing is of good utility when applied to appropriate patient cases. We have some areas in the world that actually pre-screen all patients with 0 history. They just get testing and they immigrate to Canada, and we have regions, for example, like China, where that's what happens. We know that there's a high rate of false positives when skin testing is done inappropriately. So we really want to be critical as to when appropriate testing needs to be done. And even with a positive test, if the story is not convincing enough, some will still move on to an oral challenge. So it really is nuanced to the patient's story as to when it happens. History is the first thing that really decides for us whether we pursue testing with skin testing or directly to oral challenge, regardless of what that skin test shows. Okay, and patient comfort, I guess, is the last one. Some want to see it happen on their arm, but we will still have the discussion about the rate of false positives could be as high as 40%, and is that acceptable or not?
And just add on to that, some of the things on history is we're actually listening for the items on history that tell us not to do the challenge, not to do the testing. We're listening for some of those subtle things, you know, any types of skin peeling, anything that's kind of hitting us towards like SJS spectrum at all, because those people, that is a contraindication because you could reinvigorate that part of the immune system that really doesn't let it go. So we're also listening on history for all the signs and symptoms to tell us not to proceed down the simple pathway. So a lot of it, there's to figure out who can, but there's also listening out to all that don't do it.
Great, thanks to both of you. I have a question now for Vanessa and Doug regarding the HPV vaccination. Is there an initiative in place to provide immunization for newcomers, considering many may not meet the age eligibility criteria upon arrival?
I wish there was. Unfortunately, public funding is still the same age requirements, but again, another area for advocacy.
Great, unfortunately, a short answer there, but yeah, I guess that's where it is at the moment. I think in terms of other questions, a bunch were answered in the written area, so I'm going to turn people over to that. If they had a question they had answered, but a lot of people had upvoted and it was answered there. Otherwise, I think we'll finish for today, let people get to their clinics, and I would like to thank our speakers again for coming today and presenting and giving us some tips and tools to use in the office going forward. So thank you very much to all of you.